So now we will talk about ectopic pregnancy. An ectopic pregnancy occurs when a fertilized egg implants in the tissue outside of the uterus, such as the placenta, and fetus begins to develop there. It is an out-of-place pregnancy. There are two types of ectopic pregnancy, extrauterine and intrauterine. The extrauterine, the most common is the tubal extrauterine pregnancy that occurs in 98% of cases. Among tubal pregnancies, the most common occurs in the ampulla of the salpinx. In the ovarian type, which occurs in 0.5% of cases, the pregnancy develops on the surface of the ovary, and in the abdominal type, which occurs in 0.1% of cases, the embryo develops in the abdominal organ, most commonly the bowel. Among the intrauterine ectopic pregnancies, there are cervical pregnancies between the internal and external uterine orifice and the cornual. The pregnancy develops in the intramural tract of the tube. So we can have extrauterine and intrauterine implantation sites. The most common is the tubal, which can occur in the ampulla, the isthmus, in the infundibulum, or interstitial. Then we can have ovarian or abdominal. Intrauterine instead can be cervical or cornual. Epidemiology. The incidence ranges from 1/25 to 1/250 pregnancies. The average range in the Western world is 1/100 normal pregnancies. In older childbearing mothers, it is 2/100. In the case of assisted reproductive techniques, it's more than 5/100. The recurrence rate is 15/100 after the first ectopic pregnancy and 25/100 after the second ectopic pregnancy. The incidence is increased in pelvic inflammatory disease, use of intrauterine contraceptive devices, and tubal surgeries and assisted reproductive techniques. Okay, so etiology. Etiology is mostly unknown. It may be due to any factor that causes delayed migration of a fertilized ovum to the uterine cavity through the tube, or factors facilitating nidation of the fertilized ovum within the tubal mucosa. These factors may be congenital or acquired. Congenital are tubal hypoplasia, tubal tortuosity, elongation, partial stenosis, which is very different from stenosis secondary to infections, adhesions, surgery. It can also be acquired in case of pelvic inflammatory disease, progestin-based contraceptives, pelvic surgery, tubal surgery, prior ectopic pregnancy. So the acquired ones are PID, which can induce scars and adhesion formation, progestin-based contraceptives, pelvic surgery, tubal surgery, in case of sterilization failure, reversal of sterilization, or prior ectopic pregnancy. In tubal pregnancies, the trophoblast rapidly invades the mucosa, feeding from the tubal vessels, which become enlarged and engorged. The affected segment of the tube is distended as the pregnancy grows. The following are possible outcomes. The pregnancy is unable to survive due to poor tubal blood supply, resulting in a tubal abortion. The gestational sac may be reabsorbed or expelled from the tube into the abdominal cavity. The reduction of the trophoblastic activity causes the HCG levels to drop. As a consequence, the level of estrogens and progestins produced by the corpus luteum are also reduced. This will cause endometrial withdrawal, a mechanism similar to menstruation. The pregnancy continues to grow until the over-distended tube ruptures, with consequential profuse intraperitoneal bleeding that may lead to hemorrhagic shock. In rare instances, a tubal pregnancy will be expelled from the tube and seed onto sites in the abdominal cavity, like omentum, small or large bowel, and peritoneum. And give rise to a viable abdominal pregnancy. We will mostly talk about tubal pregnancy because it's the most common. Symptoms, to repeat, the possible outcomes are tubal abortion or tubal ruptures or seed onto sites in the abdominal cavity. So, symptoms and workup. And symptoms and workup. In most cases, a woman in childbearing age with a tubal pregnancy will refer to the ER with pain and vaginal bleeding. You should collect the medical history, run some tests, and observe the patient until you can diagnose an ectopic pregnancy. The classic triad of an ectopic pregnancy is amenorrhea plus pregnancy test. Amenorrhea and positive or positive pregnancy test. Pain, variable in severity and nature, and vaginal bleeding. Bear in mind that it does not come from the tube, it comes from the exfoliation of the endometrial functional layer, and is due to the reduced production of estrogens and progestins. The pregnancy is not in the proper place, trophoblast dies and does not produce HCG. A physical examination. The patient may be blanched, pale, sweating, or with cold skin. Tachycardia and hypotension if in shock. The abdomen is tense, tender in lower quadrants, and often rigid. Uterus may be bulky. The posterior fornix is tender. Excitation, pain, and movement of cervix. If you move the cervix laterally, the pain worsens. At labs and imaging. These are two very important tests that help with the diagnosis: transvaginal ultrasound and beta HCG level. Transvaginal ultrasound may show you the pregnancy growing in the tube, in the luckiest case, or may show the empty uterus sign, no pregnancy is in the uterus because the pregnancy is outside the uterus. If the beta HCG level is less than 1500, the pregnancy may not be visible at transvaginal ultrasound. On the other hand, when the BHCG level is higher than 1500, an intrauterine pregnancy is always big enough to be seen on transvaginal ultrasound. If we see the embryo inside the uterus and we see its cardiac activity, the pregnancy is normal, even if the mother has vaginal bleeding. In this case, the bleeding is paraphysiological and is due to the trophoblast digging into the decidua. If we do not see anything inside the uterus, we have to look for the pregnancy elsewhere. We should check the adnexa, looking for masses. In the case of a tubal or extrauterine ectopic pregnancy, we do not expect to find a gestational sac. The most common images are like TENS, a non-homogeneous mass surrounded by blood and clots. If the uterus is empty, the decidua is very thin, and there is a positive pregnancy test, so you should suspect ectopic pregnancy, early miscarriage, or normal intrauterine pregnancy, younger than you expect. HCG less than 1500. So, if the uterus is empty, the decidua is very thin, and positive pregnancy test, suspect ectopic pregnancy, early miscarriage, or normal intrauterine pregnancy younger than expected. Management. It depends on HCG levels. If HCG is more than 1500 and the pregnancy is inside the uterus, the pregnancy is viable, and you should see the embryo with transvaginal ultrasound. In a normal pregnancy, the ECG doubles every 36-48 hours. If ECG is less than 1,500, we cannot see the embryo in the uterus, and the uterus looks empty. We cannot state whether the pregnancy is normal, ectopic, or there has been miscarriage. If the patient is hemodynamically stable, and we should wait and check ECG levels after 24, 36, and 48 hours. If the ECG level doubles, it means the embryo is growing and we should test the ECG level again. The pregnancy is inside the uterus. Now we should be able to see it. If the ECG level did not increase at all or is lower than the first measurement, it means there has been an early miscarriage, so a tubal miscarriage. It does not matter whether the pregnancy was intra or extrauterine. The patient is safe. If the ECG level stays the same, it means there is a persistent trophoblastic activity that does not belong to a normal pregnancy, and that may be tubal or intrauterine. The patient is not hemodynamically stable, that is, the hemoglobin level drops, she is in severe pain, or there is an abdominal mass. You should perform surgery immediately. We should perform surgery even in the case of a patient who is clinically stable but whose ECG is more than 1,500 and whose transvaginal ultrasound shows an empty uterus and no sign of fetal cardiac activity. In this case, the pregnancy is growing normally but is not in the uterus. If we see the embryo growing outside the uterus with transvaginal ultrasound, we should perform surgery immediately because the risk of tubal rupture is very high. If we do not see a fetal cardiac activity, but we see an ectopic mass and the patient is stable, we should wait and repeat the ECG and transvaginal ultrasound because there may be a tubal abortion. In this case, if the ECG level rises, you should perform surgery, whereas if it drops, it means there has been a tubal abortion. The worst situation is when ECG is less than 1,500. TSV, transvaginal ultrasound is negative, but the patient is in shock. In this case, you must run to the OR without knowing what you will find. So, a spontaneous miscarriage is a very frequent event for humans. The rate is about 15–25% of all pregnancies. In more than 60% of miscarriages, more than 60% of miscarriages are due to chromosomal abnormalities. They can be isolated or due to an error in the maturation process of the egg or spermatozoon. The symptoms of a miscarriage are the same in an ectopic pregnancy. Pain is due to the contractions of the uterus that has to expel the gestational sac. Bleeding is due to the detachment of the functional layer of the endometrial decidua from the basal layer. Treatment. We can have an expectant management. If the patient is stable, we should wait. A spontaneous abortion is not rare. It occurs in 70% of cases. You can also have a surgical treatment, mandatory in case the patient is bleeding and there is no spontaneous abortion. It can be conservative with salpingostomy. By cold knife, you put the antimesenteric portion of the tube over the embryo. The embryo is then grasped and removed. The tube is left in place. It's dangerous because some trophoblastic cells may be left there and will continue to replicate. There is the risk of secondary rupture and abdominal hemorrhage. Because of that, salpingostomy is rarely performed in case of tubal hemorrhage. And we can also do radical, so salpingectomy. That is total removal of the tube. There is no reduction in the fertility rate, even if one tuber is removed, as long as the remaining tube is healthy. Pharmacological treatment is done with methotrexate. It's an antagonist of folic acid. It is used in case of persistent trophoblastic activity, that is elevated HCG levels after conservative surgery in the case of persistent trophoblastic activity without surgery, or in the case of intrauterine ectopic pregnancy, because in this case surgery is very dangerous. In case of cervical implant, the surgical removal of the embryo may cause massive bleeding that may require hysterectomy. There are two protocols. You can have a single dose or multiple dose. Okay. Recurrent pregnancy loss. It's defined as more than 3 consecutive losses of clinically recognized pregnancies less than 20 weeks of gestation. It is emotionally traumatic, similar to stillbirth or neonatal death. It may be primary or secondary to an underlying condition. Live birth may be possible with secondary conditions. The observed frequency is higher than expected by chance alone. 15% of patients experience sporadic loss of a clinically recognized pregnancy. 2% experience 2 consecutive losses. 0.4 to 1% experience 3 consecutive losses. So 15% 1, 2% 2 consecutive, 0.1 to 1% 3 consecutive. Only 50% of cases the etiology can be determined. Etiological categories are uterine, immunologic, endocrine, genetic, thrombophilic, environmental. The most common cause is a uterine defect called septate uterus. A fibroseptum divides the uterine cavity in two parts. The outcome is the poorest, with a miscarriage rate greater than 60%. If untreated, the fetus survives in only 28% of cases. The longer the septum, the worse the outcome. The mechanism is not entirely understood. Perhaps the septum, being non-vascularized, prevents a correct implantation of the embryo. Another uterine cause is the submucosal leiomyoma. The mechanism is very similar to the septate uterus. You have a reduced vascularity, poor endometrial receptivity, and inflammation with increased cytokine production. Another immunologic factor associated with recurrent pregnancy loss is antiphospholipid antibody syndrome. It causes thromboembolism of placental vessels because of altered coagulation. 5–15% of women with recurrent pregnancy loss may have antiphospholipid antibody syndrome. And among the endocrinologic factors, poorly controlled diabetes mellitus is a cause of early and late miscarriage. If the diabetes is well controlled, the risk of miscarriage does not increase. The mechanism involves hyperglycemia, maternal vascular disease, and possible immunologic factors. Other predisposing endocrinologic conditions are thyroid disease and thyroid autoantibodies. Poorly controlled hyper or hyperthyroidism, as well as an increased rate of thyroid autoantibodies, even in the presence of a normal thyroid function, cause infertility and pregnancy loss. Thrombophilia is a cause of recurrent pregnancy loss. Thrombosis on the maternal side of the placenta may impair placental perfusion. It causes late fetal loss, intrauterine growth restriction, placental abruption, or pregnancy-induced hypertension. The relationship with early loss is less clear with contradictory information in the literature. There is also a genetic predisposition for recurrent pregnancy loss. There is an increased rate of miscarriages in first-degree relatives of women with unexplained recurrent pregnancy loss. It may be due to shared HLA haplotypes, coagulation defects, immune dysfunction, or other undefined heritable factors. About 5% of couples with recurrent pregnancy losses have major chromosomal defects. versus 0.7% of normal couples. There may be a balanced translocation or an inversion. Even if present, however, chromosomal abnormalities may not be the cause, therefore a complete diagnostic workup is indicated in the case of recurrent pregnancy losses. All women with more than 2 consecutive pregnancy losses should be evaluated. The minimum workup involves complete medical, surgical, genetic and family history, and physical examination. You should ask about the gestational age of the embryos, the presence of alive embryos, if the patient had intrauterine devices, if she had intrauterine adhesions, menstrual cycle irregularities, endocrine dysfunctions, headache, hyperprolactinemia, visual dysfunctions. You should check for endocrinological abnormalities, hirsutism, and pelvic organ malformations. The tests are transvaginal ultrasound to evaluate uterine contour and structure, presence of fibroids, septum if present, and unicornulation. Hysteroscopy, and if you see any abnormality, you can treat it, like polyps, fibroids, adhesions, septum, submucosal myoma. And in case TSV and hysteroscopy are not informative or unable to differentiate among different pathologies, an MRI is useful. If MRI is not informative, then you can perform a laparoscopy. Anticardiolipin antibody, IgG and IgM, screening for thrombophilia, TSH positive or negative, with positive or negative FT4 and FT3, free T4 and free T3, and thyroid peroxidase antibodies. Management: 50% of recurrent pregnancy loss remains unexplained. Even without treatment, the prognosis is still good. There is still a more than 50% chance of live birth even without intervention. Uterine abnormalities are managed hysteroscopically. Antiphospholipid syndrome is treated with aspirin and heparin. Diabetes mellitus is controlled at least 6 months prior to conception. Thyroid, hyper and hypothyroid should be controlled. Thrombophilia, anticoagulation, women benefit from treatment. Lifestyle modification, eliminating use of tobacco, alcohol, caffeine, and reduction in BMI for obese women. Progesterone, widely used, but studies on its efficacy are lacking. Can be applied vaginally or intramuscularly. Human menopausal gonadotropin, correcting LPD or creating thicker. LPD is LPD. Anyway, correcting LPD or creating thicker endometrium. Clinical experience supports efficacy. IVF plus minus PGD mixed results, but may be promising. So let's review the causes of the recurrent pregnancy loss. They can be divided into 6 categories: uterine, immunologic, endocrine, genetic, thrombophilic, or environmental. The most common cause is septate uterus. Then we can have submucosal leiomyoma, then antiphospholipid antibody syndrome, then diabetes mellitus, then thyroid diseases and thyroid autoantibodies, thrombophilia, genetic predisposition for recurrent pregnancy loss, in fact we can have major chromosomal defects. Okay.